I am inviting for FFR invasive and non-invasive modality chairpersons Dr. Sunaria, Dr. Joshna, Dr. Debasis Mitra, Dr. Shashikant, please come on to the dais, and moderators Dr. Muralidharan, Dr. Vinod Kumar Vilavananthan, Dr. Amitabha Chattopadhyaya, Dr. Vijay Chandra Reddy, Dr. PC Mandal, Dr. Sushil Sharma, Dr. Guru Prakash, Dr. Raju. Please come on to the dais and just start the proceeding.
Good morning to all of you. FFR is one thing regarding which a lot of data is pouring in over the last decade. If you look into the publications, each and every cardiology journal will have at least one article on FFR in all their issues of late. For the last 3 years, almost every issue there will be an article on FFR. And so a lot of evidence is pouring in, and my job is to find out whether the data supports its routine use. So what is the current concept on FFR? The presence of a coronary stenosis alone doesn't mean it is ischemia generating. There is always a complex relationship between the angiography and this, the lesion severity and the coronary blood flow. It is not always a 1:1 relationship. And coronary angiogram, now it is well known that it is an imperfect investigation to predict the outcome. And we have coronary physiological indices, both resting as well as hyperemic indices. The resting indices like PD by PA or the IFR, as well as the hyperemic indices like the FFR. And the hyperemic indices are well validated, and I'll be talking only on the hyperemic index, that is FFR. And they are now considered to be the invasive standard to identify the ischemia generating lesion. So do we have real evidence to substantiate? One, can we defer revascularization in a physiologically insignificant lesion? So anatomically it may look significant, like a 60% lesion or a 70% lesion, and that is the one that which always gives a headache, whether to deal with it or not, whether we should go on medical therapy, whether we should revascularize it or not. Because can we safely defer revascularization if it is physiologically insignificant? Then the corollary, if it is physiologically significant and but looks like only a borderline lesion, whether we should revascularize all these physiologically significant lesions, and are they going to derive any benefit out of this revascularization? And can FFR guided revascularization improve outcomes when compared with an angio guided revascularization? And should we aim only functionally complete revascularization rather than an anatomically complete one? So these are the questions to be answered with the evidence supporting. So I'll review the evidence. So this is the first and the longest follow-up trial in FFR, that is a deferred trial. So there two groups were randomized. These are people who came for elective PCI. They were randomized into two groups. One group in which they have decided to perform the PCI, the other group in which they have decided to defer the PCI. Then all these patients underwent FFR with a cutoff of 0.75. In the deferral PCI group also, if the FFR was less than 0.75, this group, despite randomization, they'll be taken up for revascularization. Those patients with an FFR of more than 0.75, they will undergo PCI as the perform group, and less than 0.75 FFR, they'll undergo PCI. So this less than 0.75 who are undergoing PCI, both in the deferral as well as in the performance group, they will remain as the reference group, and those patients with a high FFR of more than 0.75, who have undergone PCI, who have undergone FFR will remain as the perform group. And this is the first randomized controlled trial with the longest follow-up. Now the 15-year follow-up data is available. So if you look at the 5-year data, the defer group in which angioplasty was deferred and the performed group in which angioplasty was performed, there is a significant difference in the cardiac death and acute MI after 5 years. You can see the reference group, the event rate was 15.7, and in the defer group it was 3.3 and 7.9, almost double than that in the defer group. And patients free from the chest pain. If you look at the baseline 1 month early part, if you look at this, this is the reference group, there the anginal control was little bit better. But as the years go by, the other group catched up, and there was no significant difference in the angina free period. And this is the 15-year follow-up. If you look at the 15-year follow-up, this is the deferred group, this is the performed group, and this is the reference group. So perform group means physiologically insignificant, FFR of more than 0.75, but underwent revascularization. So there was no benefit. Not only there was no benefit, you can see, we believe that usually there will be, in the defer group, the target vessel lesion should progress. They'll have more events. But here, the target vessel lesions was not much when compared to the group in which the angioplasty was performed in an physiologically insignificant lesion. Significantly higher target vessel related events. So, and over the years, 15 years, 2.2% was the incidence of MI in the defer group. So what does the defer trial told us? No long-term benefits offered by PC of angiographically significant, but physiologically insignificant lesions in terms of prevention of myocardial infarction. No increase in the catch-up revascularization among the deferred group, and medical therapy provides excellent outcome in long-term management of functionally insignificant lesions. And functional significance of the lesion is the determinant of the future events. It is not the anatomy. Then the FAME study. The FAME study is a randomization of stable with some amount of acute coronary syndrome. Acute coronary syndrome, that means unstable angina, and NSTEMI with a CK of less than 1,000 units, but not STEMI patients. So total of 1,005 patients. One group angiographically guided PCI, other group the FFR guided PCI. And what is the outcome? 1 year outcome, all the outcomes, death, MI, repeat revascularization, the major adverse cardiac events, almost 1/3 difference. There is a 30% reduction in the event rate in the FFR guided PCI when compared to the angio guided PCI. And at 1 year, you can see there is a 5.3% absolute difference between in the MACE-free survival between the two groups, the FFR guided and the angio guided PCI. Not only that, a significant reduction in the number of stents used. In the FFR guided, it was 1.9 per patient, and the other it is 2.7 per patient. So the number of stents have come down. At 2 years, the same result is was persisting. Death or MI significantly lesser, the myocardial infarction significantly lesser in the FFR guided PCI when compared to the angio guided PCI. And what happened to the deferred lesions in the FAME group? The deferred lesions in the FAME group, there was a very meager number of myocardial infarctions. A late myocardial infarction, that is the one thing that we worry about when you leave a lesion, especially a borderline lesion in a vessel, and a patient, especially a patient who is presenting with an ACS, whether this will lead on to future event rate, future myocardial infarction. But in the FAME study, they found that in the deferred lesions, when they developed a myocardial infarction, the deferred group, when they developed the FFR guided PCI, the deferred patients, 8 developed myocardial infarction due to a new lesion or a stent related issue, and only 1 out of 513 developed a late myocardial infarction in the deferred lesion. So that means deferred lesions, physiologically insignificant lesion the procedure can be deferred safely. And what is there with the FFR guided angioplasty in the unstable angina and non-ST elevation MI in the FAME group? That is 30% of the patient had either unstable angina or a non-ST elevation MI. If you look at, you can see this is the stable angina group. This is the unstable angina, FFR guided PCI in the unstable angina NSTEMI, and this is the angio guided. So the survival free of major adverse cardiac events is much better in the FFR guided group. So in the stable angina as well as the unstable angina group, FFR guided PCI was found to be better in terms of the outcome. In the FAME2 stable CAD patients, here the difference is FFR positive patients, that means physiologically significant lesions, they were randomized into 2 groups. One group undergoing medical therapy, the second group optimal medical therapy with percutaneous coronary intervention. And they wanted to find out whether if you treat a physiologically significant lesion with medical therapy, whether it leads on to an increased event rate. So follow up at 1 month, 6 months, and every year up to 5 years. Can see the composite of death, MI or urgent revascularization was significantly lower in the revascularization group when compared to medical therapy in physiologically significant lesion. It's a significant difference. And 2 year, this difference was maintained. Medical therapy, higher event rate in those with physiologically significant lesion. And this benefit was driven basically by a reduction in the urgent revascularization. And another important observation is that it depends upon the severity of the lesion. As the FFR becomes more and more significant, FFR becomes less, the stenosis severity increases, the event rate increases. So when the FFR goes down below 0.71, when it becomes 0.6, 0.7, 0.6, 0.5, the event rate is increasing. So this is the randomized control data. Are these the results obtained in the randomized control data replicated in the real life scenario? This is the Korean registry, the Asan Medical Registry. In Korea, in 2008, 1.8% was the penetration of the FFR, and by 2010 it became 58% penetration, and they looked at a comparison when they were doing routine FFR and when they were not doing FFR routinely. What's the difference? They found the difference is less number of angioplasties, less number of, for example, it was 2 vessel disease angiographically, then functionally the 2 vessel disease came down, so less intervention. So number of vessels treated, number of stents used came down significantly. And what they found that less vessels revascularized when a routine FFR strategy was utilized, and less peri-procedural myocardial infarction driven the reduction in the primary endpoint. So basically it was a procedure related events that was reduced, and points to the issue in the use of inappropriate use of the stents. The largest registry so far is the IRIS FFR registry. The IRIS FFR registry, they found the same thing. As the FFR comes down, the event rate increases. And in the group with the borderline FFR, that is 0.75 to 0.8, in the FAME trials, they use the cutoff as 0.8. In the DEFER trial, they use the cutoff as 0.75. So many of the people even now consider between 0.75 to 0.8, it could be a borderline. So what happens in the borderline lesions? So borderline lesions, when they evaluated, they found that medical therapy would be a reasonable and a safe strategy, because the myocardial infarction was more in the performed group, but the target vessel revascularization in the long run was more in the non-performed or deferred group. So they matched each other. So a careful selection of medical therapy, it seems to be a reasonable option in patients with the borderline FFR. So borderline FFR, you can safely defer revascularization in selected cases. Medical therapy would be a reasonable and a safe strategy, and revascularization then should be based on a careful clinical judgment. So what we have learned from IRIS registry is revascularization was associated with a better outcome in only those with an FFR of less than 0.75. It prohibits stent implantation without an objective evidence of ischemia. And routine use of FFR leads to an outcome benefit, and FFR is a physiological biomarker demonstrating a risk continuum. Now, this is all in stable coronary artery disease. What in FFR in ACS? We have data from the PRIME registry, the famous trial, Little Rock registry, the Dynamic 3 Promalty, and the Compare Acute in Acute Myocardial Infarction. I'll go to the Little Rock registry because others too did not provide much data on the outcome. Long-term prognosis of the deferred acute coronary syndrome lesions based on non-ischemic fractional flow reserve. And when you compare the stable ischemic heart disease and the unstable disease, you can find there is a significant difference in the event rate with reference to the FFR. So FFR in the 0.75 to 0.8, significant event rate difference. This is the stable angina, this is the unstable acute coronary syndrome group. It's a significant difference in the event rate. So what we are using the cutoff of 0.8 is basically data derived from the stable ischemic heart disease that may not be applicable in the scenario of acute coronary syndrome. For example, if you see here, FFR less than 0.84, acute coronary syndrome, 11.4% was the event rate, annualized event rate. Less than 0.81, if it is, this is the stable angina group, it is much, much less. The Compare Acute trial, after successful treatment of the infarct-related artery in acute myocardial infarction, complete revascularization based on FFR, and infarct-related artery only PCI. There is a significant difference in the outcome. 85% of the revascularization group based on FFR, 85% in the same sitting of the PCI, primary PCI. Significant difference in the outcome. With complete revascularization, there was a benefit obtained when compared with the IRA only intervention. And this was basically driven by a reduction in the revascularization. You can see it's basically a reduction in the revascularization. The Dynamic 3 Promalty, also acute myocardial infarction, FFR guided PCI of complete revascularization, whether it was beneficial. There was a benefit in terms of the event rate. So what we have learned from these two trials confirm that in STEMI with multivessel disease, complete revascularization is better than an incomplete revascularization, and FFR may be used and is effective in this context. that is for a functionally complete revascularization. So evidence-based FFR utility in ACS. In acute STEMI, no FFR in the culprit lesion. In old infarction, FFR like in stable patients. In end-stage and unstable angina, high rate of reclassification for the percutaneous coronary intervention, and FFR guided appears to be safe, and there is a caveat for the clear culprit lesions. In the non-culprit STEMI and the end-STEMI ACS, FFR is reliable even during the acute phase, and it seems to be clinically useful, but it needs more randomized data for a confirmation. So should we use FFR routinely as per the current data or current evidence? Definitely yes, in stable ischemic heart disease. And a little reservation in culprit vessels in unstable angina and end-STEMI, where we need more data on it, and the data is evolving with the newer data coming up with the FAME3 and all. And probably you may utilize it in non-culprit vessels in STEMI with the two data that is available. Thank you for your kind attention.
So the title of my talk is Non-Invasive FFR, the CT FFR. The prior cardiology world was rather simplistic. The tighter the coronary stenosis, the greater the flow reduction, the increased mismatch of demand and oxygen supply leading to ischemia. So a stenosis of over 70% had a good chance of ischemia, and you needed to treat that lesion. That is the reason for decades we had this preoccupation with coronary stenosis, which is what we could fix, and CAG held the position of the gold standard. Unfortunately, 73% of the invasive catheterizations had non-obstructive coronary artery disease. So invasive cath was only effective in 27% of the patients to detect obstructive coronary artery disease. So CAG alone was not totally reliable. We started the search for a new gatekeeper for the cath lab. There was an emerging need to detect ischemia rather than obstructive coronary artery disease. We wanted hybrid imaging between anatomical evaluation of the coronaries and functional evaluation to see the impact of stenosis on myocardial ischemia and infarction. The gold standard for anatomical evaluation remained the invasive CAG, but we also had the non-invasive CT angiography as the alternative. For evaluating functionally, we had the gold standard as the invasive FFR, followed by the non-invasive ETT, echo, SPECT, PET, CT, MR with and without stress, and the CT FFR. Now, since the CAG alone was not working, the functional strategy was tried for pre-testing for ischemia. And in a very large cohort of patients, the post-functional strategy, only 38% had obstructive coronary artery disease on the ICA. So this functional gatekeeper, again, was not too efficient. The NCDR data of 660,000 patients between 2009 and 2011 showed that 64% had a pre-procedure non-invasive test, but the rate of obstructive CAD by cath was only 42%. But when we look back at the data, 78% had a SPECT and 2% had a CTA. So the gatekeepers were still not truly efficient. The functional assessment of stenosis is indeed important because anatomy is not equatable to ischemia. Multiple factors impact flow and pressure gradient to determine ischemia. It is in fact ischemia that drives management, and ICA cannot predict which lesion is going to be flow limiting and need the PCI. So this led to the invasive FFR. Studies have shown that in stenosis of over 70% had no or mild ischemia. So even when you did have an obstructive coronary artery disease, you did not necessarily have ischemia. On the contrary, in a stenosis less than 50%, ischemia may be present in 17% of the patients. The FFR is a translesional pressure ratio or ischemic potential across a stenosis at hyperemia. An invasive FFR is important for decision making to assess ischemia within the cath lab. Multiple studies have validated the FFR with a cutoff of less than 0.75 being positive and over 0.8 being negative, with 0.75 to 0.8 being the gray zone. FFR-derived ischemia-guided management improved outcome, quality of life, and reduced clinical events and costs. So the question that arose was, should you treat a lesion you see, or should you treat based on the FFR guidance? The FAME1 demonstrated that patients do better if you use FFR-guided PCI rather than angiographic guidance. In the FAME study, 5-year follow-up showed that FFR-guided revascularization improved survival free from MACE, all-cause mortality, myocardial infarction, and revascularization. So 60% lesions with normal FFR, when left untreated, had a better long-term impact. So if you had an intermediate lesion which was FFR negative, leaving them alone was safe. The next question that came up was, do patients with multi-vessel CAD and ischemia do better with ischemia-guided revascularization, which is FFR-guided revascularization, than with medical therapy alone? And the answer by the FAME2 trial was yes. The FAME2 showed that 2-year follow-up of primary endpoints such as death, MI, and urgent revascularization were lower when you compared and you treated based on FFR. The third question that came was, how often does the FFR at the time of diagnostic angiography change the treatment decision? And this was found in a third of patients. So invasive FFR came to be the gold standard. The advantage was it had a great decision-making tool, it had better outcomes, but the gatekeeper to the PCI it was, not to the cath lab. The disadvantage was the patient continued to go to the cath, it was invasive, and there was an inherent risk and cost. The aim to decrease the number of non-obstructive coronary artery diseases subjected to cath continued to need that non-invasive gatekeeper. The Promis trial was the first which showed that if you had obstructive coronary artery disease in the cath lab, and if you looked at the pre-cath, whatever form you did, you found that the CTA arm provided 72% of the patients versus the functional arm having only 47.5%. So the CTA came out to be the potential new gatekeeper, and could we further increase the positive predictive value and specificity of coronary CT to improve its role as this gatekeeper? So that led to the search of the CT-derived FFR. So this is the history of how the CT-FFR actually came into play. The CT-FFR is a computational fluid dynamics with calculation of non-invasive 3D FFR of the entire coronary bed from a typically acquired CCTA. There is no modification in the imaging protocol, medication, or radiation. It's not influenced by changes in BP, heart rate, or contractility, and it incorporates collateral flow contribution and the myocardial perfusion. The steps that we take to get the FFR-derived CT coronary angiography, you take a routine CTA, the data undergoes segmentation, a physiological model is created, laws of fluid dynamics are applied, and you come up with the fractional flow reserve. The clinical trials for FFR-CT are varied. We have validation studies, which are the Discover Flow, de facto, and the next trial, and we have the outcome studies, which are the Promis and the Platform. If you compare FFR-CT versus the coronary CTA in the demonstration of ischemia, FFR-CT is definitely the winner. And if you compare the per-patient diagnostic performance of FFR-CT versus CTA, there is a superiority of FFR-CT in accuracy, specificity, and positive predictive value. On a per-vessel diagnostic performance of FFR-CT versus ICA, there's a superiority of FFR-CT in accuracy, specificity, and positive predictive value. So definitely FFR-CT is coming out as the winner. The next trial has shown that the diagnostic performance of CT-FFR versus even FFR has a very good correlation, and FFR-CT is superior to all other non-invasive methods for lesion-specific ischemia. So it's a good balance between sensitivity and specificity, and it's possibly the best non-invasive method. Further, calcium does not interfere with FFR-CT correlation. So in the past, when 73% of the invasive caths had non-obstructive disease, with FFR-CT, you could technically cancel 61% of these patients. So there was a dramatic reduction in the invasive caths with no obstructive coronary artery disease. FFR-CT is in fact a tremendous impact as a gatekeeper, with 83% reduction in the non-obstructive CADs going to cath. So the number of cancelled caths demonstrated that even at 1 year, there was a proven safety with no adverse events. So even if you cancelled the PCI, you didn't really have any problems. The percentage treatment that changed was seen that angio-guided versus FFR-guided, 26% of the treatment strategies were changed. CT-guided versus FFR-CT-guided, 36% of the treatment strategies changed. Also, there was no change in the overall revascularization rates, because effectively, if you have an obstructive coronary artery disease that needs to go to PCI, that is always going to be detected, be it through the CT-FFR-CT or the CAG route. There was a greater improvement in quality of life when decisions were made on FFR-CT, and it was also useful in virtual stenting for pre-procedural planning for beneficial outcome. FFR-CT was also useful for stent implantation and before and after simulations. It could predict hemodynamic changes due to CABG. So the algorithm that is used FFR-CT based is that if you have a coronary CTA, if it's high risk, then you actually go to the ICA. If it is low risk anatomy, then you go to OMT. But if it's an intermediate risk anatomy, you may want to proceed to the FFRCT. If it's less than 0.75, patient goes back to the ICA. If it's over 8, the patient goes to OMT. If it's between 0.76 and 8, the patient has OMT for 3 months, following which you assess the symptoms and reassess the patient. Future applications of FFRCT will include myocardial volume to mass evaluation, where you demonstrate the relationship of available coronary volume and myocardial mass. The phenomena of low FFR without obstructive coronary artery disease is now getting better known. If the carrying capacity of the coronary arteries is too small to supply the myocardial tissue demand, then the same size vessel may actually fail to supply the greater volume of myocardium. The ratio of vascular volume and myocardial mass provides insights into ischemia, and even in mild stenosis, pathological FFR may exist. Volume to mass quantification is now becoming extremely important, and 29% of apparently anatomically non-obstructive lesions have a positive invasive FFR. Functional syntax is also useful, where FFR-CT-based decisions of best choice of revascularization between PCI and CABG is now becoming possible. Integration of FFR-CT with adverse plaque characteristics and prediction of plaque rupture is now becoming a reality, where we can discriminate culprit from non-culprit lesions. So based on delta FFR-CT, pressure, wall stress, and axial plaque stress, we can actually evaluate which is the culprit lesion, besides the diameter stenosis, the adverse plaque features, and the hemodynamic impact. So if you have a usual care cohort versus the CT FFR CT guided cohort, if you had 10 patients to start with and you went to the usual care ICA, revascularization would occur in 3 patients, but 7 of the 3 CADs would be non-obstructive on the ICA. On the contrary, if you did the CT or the CT FFR, the revascularization rate would remain the same. You would still have 3 people who had the PCI, but 6 out of them would not actually need a CAG, and 1 of them would have a non-obstructive CAD on the ICA. So effectively, you would reduce the number of just diagnostic CAGs. So if the cardiology news in the past read that FFR-CT could displace invasive tests for chest pain, it's now come to the point where FFR-CT displaces invasive tests, and we do hope in the future FFR-CT displaces all tests for chest pain. Thank you so much for your patient listening.
Morning, everybody. Respected chairpersons. Just before we go ahead, just want to thank Dr. Mona. He's doing a lot of great work in Delhi. There are 3 principal people right now doing FFR-CT, and one of them is John Lipsick in Canada, and they are almost doing it free for those who are interested. And we are trying to have a collaboration with some of our Indian cardiologists with him. One of the vendors, I believe Siemens, is at a very crucial threshold where they can give you the FFR-CT right now on their platform, but maybe it is about a year or 6 months away. So you're going to actually have this computation right at your desk, and it's really going to revolutionize. And the beauty, as what has been told, is that unlike invasive FFR, where you feel something's there, you pass a wire, and we know that serial stenosis is an issue still, here you get the whole heart, every lesion. And because of the virtual planning that is available in the software, even implantation of stent virtually can be done and see the result. So that just takes it to the next level. So for multimodality cardiac imaging, and since this is generally a cardiac audience, I've just decided to show a couple of cases. These are our own cases or cases sent to us, and show you how we have integrated cardiac imaging in a way to help the patient. So lots of options, and you see there are a lot of options there. We'll just straight away go to our first case. She's a 58-year-old lady presented with chest pain on exertion, CCS class 2. She's diabetic hypertensive. She visited a friend of mine, and as you know, with such a history, an angiogram was done. I'm just hoping the images play. There they are. So that's the right coronary, and he had some issue with injecting, but that's what it is. And then the left. So the moment he put his catheter in, severe damping, ventriculization happened, but he just gave in a quick contrast, came out, that's the circ, and then took out the catheter, again put it in, again damping, and this is the LAD. You can clearly see that there is haziness there in the left main LAD area, and then a quick LAO-caudal view, and you can see the same issue. He was trying damping, just wanted to give in some injection. So this was it, and then he had to quickly come out, and this lady started getting pain, and blood pressure fell. So patient became stable after the procedure. So now what? So definitely, as you saw in those pictures, the left main LED area was a little hazy, questionable significant stenosis, there's damping, we don't know whether it is wall, we don't know whether it's lesion, and this patient, you know, was symptomatic. She's a high-risk patient, so we wanted some kind of a confirmation of what was happening. Now, what are you going to choose? You want to do an FFR, we just discussed that with the last couple of speakers, but the moment the catheter goes in, there is a significant damping, it's going to be an issue. IVS, again, same issue, cost issue. Would you like to do a stress maybe? Seeing that haziness, left main area, I think we're dealing with a potential trouble. We've had a couple of patients in our large 10-year decade of experience with stress maybe, adenosine, even with adenosine, where we've had patients collapsing, had to be shifted to the cath lab, emergency PCI to be done. So we elected in this particular case, and this case was referred to me, to do a CTA. How is it going to help? So looking at stenosis, we can do that accurately, plaque morphology, and also the distal scar. Now these are the images. You can see the RCA was relatively clean, no issues there, despite the problems with the catheter. And here you see the problem. There's a significant left main osteoproximal LAD calcified lesion. I hope you can see that clearly, extending right in from the aortic root. And that's the reason why the moment his catheter tube went in, there was a significant issue. And again, just a different view, clearly showing your osteoproximal left main extending into the LAD. And again, you can see here, and this is the diagonal coming off. And here you can see the circ OM, and you can even here see the osteoproximal circ has a tight lesion there, extremely tight lesion. So with this kind of history, patient being symptomatic, and you have a clear confirmation here on the CTA, this patient was electively sent for a bypass, and we put in 2 grafts here because we saw that the circ also had a significant lesion and LAD was also significant, and we just left the RC alone because you can clearly see that there were just a few mild calcified plaques, although the angio was not great on this patient. So here is where how interposition of a non-invasive test helped this lady to achieve a good result. Now just coming to the role of CTA, I've had about, at least in my experience, 5 cases where the angio was done and then the patient referred back to me, especially for left main. And you can see here the picture on the right if my cursor moves. You can see here, all we can see is that we would imagine this to be a significant left main. When we did the CT, you can see, yes, there is a significant lesion. You can see that here. And there's another patient of ours where the angio was done, they thought it was significant left main, referred back to me because for a doubt, and you see the beautiful osteoproximal CTA absolutely clear of any atherosclerotic plaque. So just to give you an idea how CT is so good, especially in this particular area. And this is data from Israel where they have shown in a couple of cases how when the angiogram was done and there was a borderline left main disease, CT clearly helps in risk stratifying these patients as to those with severe, those with mild, and those with the borderline. You still had 1 or 2 patients in their series with borderline, and they were okay to undergo an adenosine, maybe is the investigation of choice in this particular group. And as Dr. Mona said, this would also be a great case to do a CT FFR because it's borderline. But this is where the role of CT has come in. To really elucidate left main lesions, especially and also in those patients where the angiogram is done, you're sure of left main, you want to do a left main intervention. We heard that the first day. CT is a great tool to look at the left main cross-sectional area. It's a great tool to look at the entire segments of the left main, the ostial LAD, ostial L6, to see where you can put the stent. You can do a lot of virtual planning before you go in for a critical left main intervention. Moving on, this is a 45-year-old gentleman, risk factors are there, hypertensive diabetic. He's had an anti-wall MI, he's been thrombolized outside, angiogram done in a peripheral center, 2-vessel disease, and come in with severe LV dysfunction. The predominant complaint at this point of time, he was actually referred to us for a bypass surgery, and he has significant breathlessness. on diuretics. And this is the ECG. You can clearly see there's a QRBB. There's still ST elevations in V1 to V3 persisting almost a week after the incident. And these are the angiogram. These are still pictures. You can see that there is a total cutoff of the LAD here. Because it's not moving, but anyway, yeah, here it is. Osteoproximal cutoff of the LAD. The right is a non-dominant artery. The left circumflex is dominant. No lesions there. Now, if you look at Allman's data, and I know we've been just bombarded by various viability studies like the Stitch, where there was no clear result. But this is great data from Allman and all, large number of patients, clearly showing that if you revascularized a viable myocardium, you get a death rate of around 3.2%, and it just goes sky high almost 5 times if you keep that patient on OMT. On the other hand, if you're going to revascularize non-viable myocardium, you're going to end up with slightly more mortality than keeping these patients on medical treatment. And if you know the kind of pharmacology that we are having today, especially the sacubitril combination, you know that we have great drugs today for optimal medical treatment. So looking at this data, we went ahead and did an MR, which is the practice in our institution. I'm sure some of you would have been doing PETs, but we like MR. And so you can clearly see there's a short axis view. There is scarring here in the anterior septum. And this is the 2-chamber view. Again, you can see the wall motion abnormality. You can see the white scar here, showing that there is gadolinium enhancement. The 4-chamber view, again, you can see the dyskinetic segment. The dark area, I'd like you to visualize, and I'll talk about it a little later. And this is the 3-chamber view playing out the entire anterior septum. You can see the dense white scar, that's gadolinium, and the black areas, the dark areas, are what we would call on MR as a microvascular obstruction. And seeing the thickness of the scar and the extent of the scar, the presence of microvascular obstruction clearly tells us that this LAD is clearly non-viable and is unlikely to improve post-revascularization. And this patient then went ahead and was kept on optimal medical therapy, and about a month later, the ejection fraction was still around 28 or 29%. We just did an MR without contrast, and this patient had a prophylactic ICD. So again, the role of MRI in this situation, where doing a PCI would have been fraught with danger and would have been a complex procedure, a lot of cost, with possibly no result. However, that particular amount could have been kept, and prophylactic AICD could have been implanted. So again, 54-year-old gentleman, exertional chest pain since a week. He's diabetic, no other cardiac history. He went for a pilgrimage, had some chest pain, was admitted somewhere, given some first aid, and then sent over. So we did the angio. You can see that there's an RC at proximal total occlusion here. The left side was completely normal. I've just omitted because of lack of time. And then I would just like all of you to just look at this recent meta-analysis which was published in JACC Intervention, showing the role of CTA in this kind of a complex CTOs. And within a month from now in our IG CTO meeting, we are going to be showing some the role of CTA in this particular population. So when we did the CT on this particular patient, this is what we got. A very short discrete segment, nice tapering, and there's no side branches, and a very beautifully seen distal vessel. So we could do the measurement, and I'm just going to show you what we do in our lab. So we look at lesion length, we look at curvature, axis, side branch location, side branch angles, distal vessel caliber, and the plaque character, very important when we are trying to choose hardware, calcium, no calcium, non-calcified plaque, thrombus, for example. That really helps the interventionist. So we have now come up with a score which is now validated, called the CT Rector score. And you have various parameters. I'll just quickly run through them: multiple occlusion, blunt stump, severe calcification, bending, second attempt for the CTO, duration of CTO. And in this particular case, I gave a 0, so the difficulty was very easy, and our intervention just went ahead and did the job. So we just did a PCI to RC without any problem. So this is the way how CTA really helps in elucidating and making life easy for the intervention in a CTO. And I'll just run through some of the steps that we do. The first would be identification of the CTO. You can see here in this patient, ostial L6 or proximal L6 occlusion, but this is exactly what we see on the image, on the CT image. So we have the whole segments played out. We look for viability in the same area. We have a dual energy scanner, so we look for areas of thinning, dark areas here, and then if they are there, then there's no point opening that vessel when there's no viability. The third thing we look at is procedural success. I just went through that, so we can look at all these characteristics of the plaque. And the fourth thing is the registration of the image, and you can see this is the angio and this is the CT. So we just register it, make sure that everything is done. This is called pre-procedural planning. And finally, we do a fusion imaging in the cath lab where we fuse the CT image onto the angiogram, and then it becomes very easy when the operator is using the guide wire. He knows exactly where to go and where to turn. And most importantly, when we call these patients up for a 6 months, 1 year follow-up, you see very beautiful, pristine stents can be visualized on CT. Don't have to do an invasive angiogram again. So we know the limitations of traditional angiography. I'm not going to go into it, but I'll just focus on CT being a great non-invasive tool. It gives you the chance to do plaque characterization, especially calcification for the interventionist to look at. 3D volume of anatomic data, so there's no overlap when you do the CT. And you can look at the data in infinite views, do a lot of planning, and go ahead. The last case, I'll just take permission from the chair for 2 minutes. 48-year-old lady, chest pain with an MI. She came to the ER and she was thrombolized outside with persistent chest pain. 2D echo revealed a moderate pericardial effusion. Now, what are you going to do in this patient? Is it a kind of a ongoing ischemia? What is this pericardial effusion? The echo just shows pericardial effusion, doesn't show anything else. Do you want to do a TE and see if there's any kind of a rupture, tear? Very difficult in this situation. Patient was not hemodynamically very comfortable. Doing an MRI would have taken a lot of time, and the current, you know how we are with MR, it takes a lot of time to acquire the coronary data. It becomes difficult to evaluate it. Are you going to do an angiogram in this lady? We know that if there is a possible rupture, the first heparin injection that you give is going to just, blow out that small little rupture site. So we've elected to do CTA. We have a 2-year data, and I'll just show a couple of images. So here is a CT that we did on her. You can see the rim of pericardial effusion all around, and you can clearly see here there is contrast extravasation here into the myocardium. This can be more clearly seen in this composite image. You can see that this is the rupture site, this is the contrast excavating into the myocardium. There is areas of decreased perfusion along this area. These are dark areas. And we also do get the coronaries, by the way. And you can see that the culprit vessel is the OM, and it's completely occluded beyond that point, with areas of decreased perfusion, which would indicate that that muscle is really not viable. And this is what we have published. We have actually published 10 cases like this, where we have used CTA in these kind of situations, diagnosed ruptures. Out of the 10 cases, we have lost 2 patients because one, the patient refused to undergo CABG. The other case was actually our first case where the cardiac surgeon refused to believe that CTA is a great tool for diagnosing rupture. Both the cases we lost. So this lady luckily agreed, and then she just went ahead and we just did a pericardial patch repair, didn't bother to fix the OM or graft to the OM because that was an infarcted area. With this, I'll just close, and thank you very much again for your patient listening.